For the physician's breakout session, I would like to introduce Dr. Elizabeth Sherwin. Dr. Sherwin graduated from Virginia Commonwealth University for her medical degree. She did residency, fellowship in cardiology, and also fellowship in electrophysiology at Children's Hospital Boston. She served as the director of electrophysiology at British Columbia Children's Hospital in Vancouver, and then she returned home to the greater DC area, where she now is on faculty at Children's National Medical Center in Washington, DC. Again, I'd like to welcome Dr. Sherwin, and her title of her talk is Phenotype Resuscitated Sudden Cardiac Arrest, What to Do When You Have No Other Signs.
Thank you so much, Tony. It's hard to follow Dr. Ackerman. Please jump in if you don't hear me or can't see my slides, but I'm going to push forward in the interest of time, 10 minutes for a big topic. But it's great to be here with everybody, if not only virtually. In the next 10 minutes, we're going to talk about what to do with a resuscitated sudden cardiac arrest patient who has no phenotype, what to do when there's no other signs. My only conflict of interest is not relevant to today's talk. So sudden cardiac arrest or aborted sudden cardiac death is rare, but it's very memorable, it's frightening, and it's really challenging, sometimes medically, of course, and also emotionally for the staff and the families. Our goal after the medical stabilization occurs is to elucidate the etiology of the arrest. What is the underlying diagnosis? Why did this patient have this? To prevent recurrence in that patient, of course, and to also screen the family to evaluate for other at-risk individuals and prevent further cardiac events. If there's no clear hemodynamic, structural, or cardiac functional condition found, then we often term that SADS, or the sudden arrhythmic death syndromes. These are primary electrical conditions. When I think of what causes a teen or young person to collapse suddenly and have a cardiac arrest, I think of three general buckets: the anatomical issues such as cardiomyopathies or congenital heart disease, electrical issues such as Wolff-Parkinson-White with pre-excited atrial fibrillation, polymorphic ventricular tachycardia or torsade de pointe, and ventricular fibrillation. And of course, the other things, acquired conditions like myocarditis, pulmonary hypertension is another congenital disorder. Coronary artery disease, though rare, can happen in young individuals with familial hypercholesterolemia, and commotio cordis and non-cardiac issues. So once there's been a sudden cardiac arrest and a patient is admitted, how do we make the diagnosis? Well, typically we're looking for the phenotype. We know the event, the arrhythmia, if it was documented at the time of the presentation, but what is their phenotype? What's underlying that background? The phenotype, of course, is a set of observable characteristics or traits of an individual resulting from the interaction of their genotype or DNA with the environment. This can be physical characteristics, behavior, clinical findings. And of course, our bread and butter when there's a new patient admitted is an EKG and imaging with an echocardiogram. Though we never want to find this, sometimes the EKG and the echocardiogram can give us a very clear answer with very clear history and guidance on management options. Sometimes the EKG alone can give it away. For example, in this 12-lead electrocardiogram, this is sinus rhythm with Wolff-Parkinson-White or pre-excitation. And of course, these patients are at risk for pre-excited atrial fibrillation, which can degenerate to VF and result in hemodynamic collapse. Thankfully, ablation is curative. So there's always a little bit of me that crosses my fingers when there's a new arrest patient that it could be WPW with a simple ablation to treat them. Other times, the EKG gives us clues for one of the inherited arrhythmia conditions. This is a patient with long QT type 3. He presented with sinus bradycardia, very abnormal T-wave morphology, which is the most striking. And as Dr. Ackerman pointed out just now, his raw QT was 496, which doesn't tell us an entire story, but the corrected QT was low or normal at 450 for this post-pubertal male. However, the look of the T-wave was the most striking and the most suspicious for this young man. But what if our EKG and our echo are normal? There's no phenotype other than the presenting event. Then what? Well, we keep looking, of course. That's only the top of the scratching the surface of our diagnostic capabilities. And when we don't see anything obvious by echocardiogram or WPW, then we're thinking more of the inherited arrhythmia syndromes, primarily the ion channelopathies, and I include arrhythmogenic right ventricular cardiomyopathy in this category, as the electrical abnormalities can precede the myopathic changes that are visible on gross testing, and therefore they may present with a relatively normal looking echo, but arrhythmias. So here's an example of a 14-year-old young man who was had a history of attention deficit hyperactivity disorder and fetal alcohol syndrome. He was at school one day when he felt lightheaded during recess, and as teenagers tend to do, apparently thought it was a good idea to drink a Monster energy drink. While standing in class shortly thereafter, he had loss of consciousness and a cardiac arrest. Thankfully, his school had an AED, applied it, and found that he was in polymorphic ventricular tachycardia, and he received 3 shocks with return of circulation. This Monster energy drink was the 3rd patient that I've seen have a cardiac arrest after drinking an energy drink, and their motto of unleashing the beast, I think, is very appropriate. It certainly did that for this young man. So of course, beyond the EKG and the echo, we want to know history. The history is so critical. Does that patient have any past history? Have they had any past symptoms? Even if this is their first time being, presenting for care, they often have previous symptoms that were not discovered or evaluated. And of course, the prodrome, the context, the family history. In many cases, we may not be able to ask the patient this if they're unconscious, or the family may not be present or have witnessed the arrest. So then we go to our menu of options for our diagnostic evaluation, far beyond a basic EKG and imaging. From an electrical evaluation, we can do simple tests to signal average ECG, available in many centers, that's primarily looking for arrhythmogenic cardiomyopathy. High-lead EKG by moving up the leads to the second intercostal space to bring out a Brugada pattern that might not be seen at baseline. And here I'm really talking about the acute presentation and evaluation after an arrest, not an outpatient relative. Beyond the echocardiogram, a cardiac MRI or CT scan can provide additional 3D imaging for function and anatomical definition. And occasionally we might consider a cardiac catheterization with angiography if the coronary arteries are not well seen or there's other questions. From a provocative standpoint, this is where the electrophysiology really gets to be better evaluated, with some tests to try to bring out changes. A resting electrocardiogram is not present or is not the entire story and may not show the entire patient's history or phenotype. So an exercise stress test is certainly one of our best if the patient is ambulatory and able to, after a cardiac arrest, to look at QT dynamics and inducible ectopy or arrhythmias. Procainamide challenges and other sodium channel blocker challenges can also be done for Brugada, epinephrine challenges to try to bring out long QT or evidence of CPVT, and occasionally, though less frequently, an EP study for ventricular stimulation and pacing. Have to, of course, talk about genetic testing. That is worth mentioning because oftentimes the clinical bedside team wants to go straight to genetic testing, but it's worthy of thought and pause. Just last month, the Heart Rhythm Society and Asian Pacific HRS published this expert consensus on genetic testing and other evaluations. And they note very appropriately that focused genetic testing can help with the diagnosis, but it really requires thoughtful consideration because it could be misleading and more confusing. But if there's no suspected phenotype, with appropriate genetic counseling, we can do targeted genetic testing for arrhythmia conditions. And that's here a class 2A for a young individual with an unexplained cardiac arrest. So while we wait for the genetic testing, because of course we won't have that back for several weeks, now what do we do? Well, at this point, I would presume a diagnosis of either idiopathic ventricular fibrillation, a diagnosis of exclusion, or concealed arrhythmia, inherited arrhythmia syndromes, where their phenotype is just not evident at that initial evaluation. So of course, we move forward and we treat them to protect them. An ICD, secondary prevention ICD after a cardiac arrest is very standard as long as they meet other criteria with expected survival of a year, etc. I would advocate for beta blocker therapy. There's not a lot of evidence for this, not a lot of data in this particular situation, a pediatric patient with a phenotypically negative cardiac arrest. However, there's very little downside. We know that other medications, amiodarone, quinidine, beta blockers in other situations like heart failure have been shown to be beneficial. I think that the downside is low. And so I typically, if there's no contraindication, I would start a beta blocker to reduce the risk of a recurrent ventricular arrhythmia. And of course, I follow lifestyle interventions as if they had a confirmed diagnosis of long QT or Brugada, for example, by encouraging excellent hydration, reporting and paying attention to symptoms, avoiding QT prolonging medications when possible, treating fevers like Brugada syndrome, and avoiding substances that may provoke an arrhythmia. Looking in the literature for evidence on this, it's few and far between for this particular secondary prevention for an unclear etiology of a cardiac arrest. But back in the 90s, Dr. Silka and all showed that for secondary prevention ICD, survivors of cardiac arrest did use their ICDs appropriately. Among all comers, here circled in red, the idiopathic ventricular fibrillation were less likely to use their ICD again, but other conditions certainly did. When I look for evidence to support what medication is going to be most efficacious, how often do patients use their ICD in these phenotype negative pediatric arrest patients? It's a lot of crickets. I think this is an excellent area for future research and is an ongoing project of collecting information on pediatric cardiac arrests. Family screening is critical, of course. Just to touch very briefly, it's not only logical, as many of these conditions may be inherited, but it's fruitful. Among adult survivors of cardiac arrest from the CASPER study, 17% had confirmed diagnoses of arrhythmia conditions. In this pediatric study by Guiducci et al., 13% of families had a pediatric patient or relative identified with an inherited arrhythmia syndrome. The really other critical part of evaluating and managing these patients is their follow-up and reassessment and reassessment. Every time I see the families, I repeat the family history. Have there been any new cardiac events for people? Or happens probably more frequently that they discover an existing family history that they were previously unaware of and their relatives had not shared with them. That can help elucidate the phenotype. I repeat relevant clinical testing as the phenotype can evolve over time. Our EKG is not static. And review genetic testing. If there was originally a variant of uncertain significance, go back, see if that had changed at all. Has it been reclassified in a pathogenic or likely benign direction? And if there was initially negative genetic testing, no variants identified, if 3 to 5 years have passed, we're learning so much more, it's worth discussing the benefits of repeating genetic testing at that time. Very quickly, this study by Mattesini and all showed that with their initial young patients with unexplained cardiac arrest, only 50% had a cause diagnosed initially. And during follow-up, 20% had their diagnosis changed, either from an idiopathic VF to a confirmed condition, or one arrhythmia condition to the next as their phenotype changed. So back to our young man, in his recovery in the ICU, he had the testing that was mostly non-invasive and mostly not helpful. No clear phenotype came, though he had some abnormal repolarization. So a long QT panel was sent based on both his EKG and the epinephrine challenge and the adrenergic type of potential setting in which his arrest occurred. He was started on beta blockers and an ICD was implanted. What I didn't share initially, and of course we told him not to drink any more energy drinks, what I didn't share initially was his family history. So here's our proband. His genetic testing ultimately came back with a variant of uncertain significance in SCN5A. His mother had had a cardiac arrest at 33 years of age and unfortunately passed away from cancer 2 years later. He has 2 full siblings. Their grandfather died of a heart attack. And when I hear that word, I always ask clarifying questions because that's a common language used that may not indicate a myocardial infarction, but could have been an arrhythmic event. She had another partner and he had another half brother. And those siblings were tested, 2 of whom had the VUS. And then there's yet another partner who had also died suddenly with additional relatives not yet completed. So in follow-up of greater than 4 years, this young man has never shown a true long QT phenotype. He's received no shocks from his ICD. And as of today, his VUS remains a variant of uncertain significance. But we push forward and continue to treat. Even when there's no clear diagnosis, we do our best with the secondary prevention ICD. I would advocate for beta blocker therapy, lifestyle precautions, follow-up and reassessment, reconsidering the information, and of course, supporting the family and their mental health. Thank you.
Okay, thank you, Dr. Sherwin. let's see, we have one question, but I think we'll move forward and we may handle it at the end. So thank you very much. Great presentation.